Bismillahirrahmanirrahim. Today we will have case quiz number 4. Case data: 63 years old male. General symptoms: fatigue, weight loss. Musculoskeletal examination show bilateral hand arthralgia with no definite arthritis for few months. Skin shows blotchy rash over the trunk, with blue to purple net-like rash over the abdomen and thighs. GIT and abdomen: central abdominal pain after each meal, with no organomegaly. Genital organs: attacks of testicular pain. Laboratory investigations: CBC within normal with very mild anemia and thrombocytosis, very mild also. ESR shooting 82, CRB shooting 94, rheumatoid factor negative, anti-CCB negative, ANA negative, and ANCA negative. This case is not so rare such as the previous cases. It is more or less more common than the previous 3 cases. You can, as usual, stop here and think for or search for the answer. So, what is the diagnosis? The answer is I think it is easy today. It is not so rare case. It is one of the vasculitis, middle vessel vasculitis, polyarteritis nodosa. Yes, polyarteritis nodosa. The symptoms that cause most concern in this case is abdominal pain after each eating or after meals. Such postprandial symptoms raise the suspicion of mesenteric ischemia. The rash over the abdomen and thigh is characteristic of livedo reticularis, and the patient's marked inflammatory response is somewhat out of keeping with his otherwise relatively mild clinical presentation. The possibility of vasculitis must therefore be considered in this case. Vasculitis can also cause marked constitutional upset and normocytic anemia and thrombocytosis, all of which are evident in this patient. The symptoms that point to a particular diagnosis is testicular pain, which occur most frequently in polyarteritis nodosa specifically. Polyarteritis nodosa is an uncommon vasculitis of small and medium-sized arteries which lead to a variety of presentations. The most common features are listed below: constitutional malaise, fever, weight loss, cutaneous palpebral ulcerations and livedo reticularis, musculoskeletal myalgia, arthralgia and or arthritis, renal glomerulonephritis leading to hypertension, gastrointestinal mesenteric angina, neurological mononeuritis multiplex, stroke, seizures, genitourinary testicular pain. These are the most common features of polyarteritis nodosa in general. In the current case, we have the weight loss, we have the livedo reticularis, we have the arthralgia, myalgia, we have, of course, mesenteric angina and testicular pain. The diagnosis of polyarteritis nodosa can be difficult, however, as there are no diagnostic serological markers and the autoimmune profile is characteristically negative. There is an association with hepatitis B, and hepatitis serology should be checked in all patients with suspected vasculitis, especially in the endemic areas of hepatitis B infection. Once the diagnosis is suspected, a tissue diagnosis should be sought from a biopsy of an affected organ, such as skin, testicle, and sural nerve. Angiography is the investigation of choice if biopsy is not possible, and is crucial in this case to investigate and delineate mesenteric arteries. Typical findings of mesenteric arteriography in polyarteritis nodosa are small aneurysms, occlusions, and stenosis. The treatment of polyarteritis nodosa depends on the extent and severity of the disease, but steroid-sparing agents, and cyclophosphamide are all used commonly. This patient would certainly require high-dose steroid and cyclophosphamide to prevent intestinal ischemia and infarction. Plasmapheresis and antiviral therapy are recommended as alternative treatment for patients who are positive for hepatitis B infection. And finally, thank you very much for your attendance, and we will meet you next time with case quiz number 5. Wassalamu alaikum wa rahmatullahi wa barakatuh.